All right, let's dive right into a critical topic, preventing recurrent attacks of acute rheumatic fever. Now, we're not talking about treating that initial strep throat. We're going a step beyond, into the world of secondary prevention. This is all about the crucial interventions that protect the heart long after that Group A strep infection is just a memory. So let's break down the standard of care. So here's how we're going to break this down. First, we'll tackle the why, that immunological echo that causes the disease. Then we'll get into the cornerstone of prevention, figure out what to do with penicillin allergies, and walk through some real-world clinical cases. After that, we'll test our knowledge to make it stick. And we'll wrap up by talking about the long-term commitment this all requires. Okay, first things first, the immunological echo. You see, to really master the treatment, you have to get to the heart of the disease itself. We have to understand where it comes from. Now, this is absolutely key to understand. Acute rheumatic fever isn't an active infection. It's what we call a sequela, a kind of ghost of an infection past. The whole problem starts when the antibodies your body makes to fight off a Group A strep infection get confused. Through a process called molecular mimicry, they go rogue and start attacking the body's own tissues. It's a case of friendly fire. Think of it like a chain reaction. It kicks off with a totally common Group A strep infection. The immune system, doing its job, pumps out antibodies. But then comes the critical mistake. Those antibodies don't just target the strep bacteria. They cross-react with our own tissues, especially the delicate valves of the heart. This triggers inflammation and can lead to permanent, irreversible cardiac damage. Section 2, the prophylactic cornerstone. So now that we understand the cause, this misguided immune attack, let's look at the solution. This is the standard, evidence-based regimen for stopping these damaging attacks from ever happening again. The undisputed champion, the gold standard for prevention, is right here. 1.2 million units of benzathine benzyl penicillin. It's a long-acting formula, and we give it as an intramuscular injection every 3 to 4 weeks. The whole point is to keep a steady, low level of the antibiotic in the system to knock out any new strep infection before it can even think about waking up that dangerous immune response. And this treatment, well, it's not a short-term fix. That number you see here, 5, that represents the absolute minimum duration of therapy after the last attack. And depending on how much the heart was affected, this can easily stretch into decades, or even become a lifelong commitment to keep that heart safe. All right, so that's the ideal scenario. But in the real world, things get complicated. What do we do when our gold standard treatment, penicillin, isn't an option? This brings us to Section 3, handling penicillin hypersensitivity. So the first step is to be a detective. You have to really dig into that allergy history, because not all reactions are the same. You know, a history of a mild rash, some hives, that might allow for a very cautious, supervised rechallenge. But a history of a severe reaction, like anaphylaxis or Stevens-Johnson syndrome, that's an absolute non-negotiable contraindication. We have to avoid penicillin entirely. For these patients, we have to pivot. We switch to an oral alternative, phenoxymethylpenicillin, 250 milligrams twice a day. Now, this gets us around the allergy problem, but it introduces a huge new challenge. The success of the therapy now rests completely on the patient's ability to be perfectly adherent, twice a day, every single day. Okay, theory is great, but let's see how this all plays out in practice. Section 4 is all about taking this knowledge and applying it to a couple of common clinical scenarios. So let's picture our first vignette. This is our textbook case. A patient comes in needing secondary prophylaxis after a documented ARF attack, and they have no known drug allergies. Pretty straightforward. The management plan here is exactly what you'd expect. We go right by the book. We start the benzathine benzyl penicillin via IM injection, get them scheduled for their follow-ups every 3 to 4 weeks, and this is the most important part. We counsel them. We have to make sure they understand the critical importance of sticking to this plan for at least 5 years to prevent long-term heart disease. Now, Vignette 2 throws a wrench in the works. The patient needs the same prophylaxis, but they have a documented history of anaphylaxis to penicillin. This one thought changes our entire approach. Here, it's all about mitigating risk. Rule number 1, we absolutely avoid all penicillin-class drugs. Instead, we prescribe that oral alternative, phenexmethylpenicillin, 250 milligrams twice daily. And in this case, the counseling becomes even more critical. We have to stress that missing even a day's worth of doses could leave them completely unprotected. Fantastic. We've covered a lot of ground. So now let's do a quick self-evaluation just to make sure these key concepts are really locked in place. Okay, first question up. Let's go all the way back to the beginning. What's the agent that kicks this whole process off, and what is the core mechanism of the disease? That's exactly right. The culprit is Group A Streptococcus. And the pathophysiology, the thing that causes all the damage, is that autoimmune response driven by antibody cross-reactivity with our own cardiac tissue. Next question. Let's get specific on the treatment. Outline the standard prophylaxis for me. What's the agent? What's the route, and what's the frequency? Precisely. The standard protocol is our long-acting benzathine benzylpenicillin given intramuscularly every 21 to 28 days. You got? And for our final question, let's talk about the long game. What is the minimum recommended duration for this prophylaxis? Right again. The minimum is 5 years, starting after that last documented acute attack. And it's that long-term commitment that is absolutely essential to prevent that cumulative and often silent cardiac damage. And that idea of a long-term commitment brings us perfectly to our final section. Let's end with a perspective on what this all really means for our patients and for us. It really all comes down to this single thought. The true battle isn't won during the drama of an acute hospital admission. It's won in the quiet, consistent, and sometimes monotonous discipline of prophylaxis. The real victory is found in that unwavering consistency, month after month, year after year. That is how we save hearts.